Annette Neylon, welcome. And nice to see you here this morning. Annette Neylon completed her training in haematology in Newcastle upon Tyne in 2003, obtaining a fellowship to the Royal College of Physicians and Royal College of Pathologists, as well as completing an MD in the field of chronic myeloid leukemia. He worked as a specialist haematology in the UK before moving to Southern Blood and Cancer Centre in Dunedin as principal lead of pathology. She has acted as principal investigator in several clinical research trials. In addition, since 2018, Annette has been a member of the RACPEZ Joint College Training Subcommittee for Haematology, helping to promote training in haematology in New Zealand. Annette took the role of New Zealand Counsellor for the Haematology Society of Australia and New Zealand in 2001. Since 2022, Annette has worked for the New Zealand Blood Service, combining haematology and transfusion medicine. And when not working, Annette functions as a taxi driver and coordinator and sideline cheerleading for her son. Thank you, Annette.
Thank you. Well, it's nice to see you today. I'm going to talk you through myelodysplasia, explain a little bit about the biology of the disorder and about what we might expect to see in the future going forward. So to start off, that one. Okay. So what is myelodysplasia? Well, it's a group of syndromes. So in other words, there's no one specific marker that we know of, but basically abnormal bone marrow stem cells produce abnormal blood cells that come out into the circulation. And these cells don't grow properly, and they often die quite prematurely. So we find when we take blood that there is a reduced number of red blood cells, which are normal, white blood cells and platelets. But those cells that do survive often have some poor quality or lack of function and are abnormal in appearance, and that's what we call dysplastic. These cells are released from the bone marrow into the peripheral blood, and people often have a very active bone marrow, but quite a low number of circulating blood cells. So what happens if you don't have enough red blood cells, white blood cells, or platelets? Well, you become quite fatigued, you're more susceptible to infections, and you might have some more easy bruising or bleeding. So the story starts here. Basically, there is a stem cell that has got a possible number of choices in what it's going to become. So it's quite a lucky cell to start off with. The maturation choice occurs and decides to become a myeloid progenitor. And then the myeloid cell goes on to divide into all different possibilities from there. So when we talk about myelodysplasia, it's often what we call a stem cell dysfunction. Once it's made that decision to become a myeloid cell, it can't go back. So it's on a pathway, it's on a journey, and it's down one bus route and you can't hop off. It can, however, develop into a red cell, which is called an erythrocyte, a platelet-forming cell, which is a megakaryocyte, or a cleaning up kind of cell, one that munches away all the badness, called a monocyte, which develops into a macrophage. And then there are granulocytes, which we also call neutrophils. So those two terms are referring to the same cell. So where did this name come from? Well, myelo is from the Greek, meaning marrow, and dys means some sort of dysfunction or oddness. So it's an odd myeloid series. It is what we call a clonal stem cell disorder, and I'll describe what that means. But you get some maturation, so they are trying their hardest to develop normally, but they're abnormal. And it is a cancer. Some people determine that it's a pre-leukemic phase, but there are a proportion of people who will go on to develop leukemia. So what is a clone? Well, you might remember way back, there was Dolly the sheep, who was cloned. And basically, it's one cell that is genetically identical and develops into a clone that only comes from that very one original cell. It really should have been destroyed because it should have been recognized as abnormal, but it still has the ability to keep on being present and dividing. What you do find, however, is that you have what we term ineffective hematopoiesis. So what you do make isn't working very well. When you look at someone's bone marrow with myelodysplasia, it's actually quite full. And as you can see in this diagram here, this is what we would call normal. And we all have fat spaces in our marrow. But what happens in myelodysplasia is that you've got an abundance of cells. They're just not doing their job properly. So how do we diagnose it? Well, pancytopenia, which means all of the blood counts. So pan means all. Cytopenia means low blood counts. It's quite common as we get older. And you also get a number of weird cells, but it can be a bit of a mixed bag. So every case is different, but there are some sort of common themes to it. So we recognize the syndrome being similar in certain ways. When we look at red cells, the arrow pointing at the top there is showing that cell has actually got low amounts of hemoglobin in. So there's a larger proportion of the white middle bit than there is of the red bit. But we might also see cells like the one that's below the arrow where it's almost fully red. So there's a wide variation in that. These cells here are the early they still have their nucleus. So these are red cells that are seen in the marrow before they start to come out into the peripheral blood. And as they come out, they lose their nucleus. But here you can see that there's all these blue bits, and that's iron deposited around the nucleus. And that's called a ring sideroblast. And just to digress a bit, sidero is also from the Greek, which was the stars. So consider was from thinking about the stars or dreaming of the stars. And that's where this term comes from. There you go, my Latin and Greek from school come in handy sometimes. So reticulocytes are what we refer to as very, very newborn red cells. And sometimes they still have a trace of the nuclear membrane stuff still left around. So when we look down the microscope, they sometimes look a little bit more blue than normal red cells. And in myelodysplasia, the number of reticulocytes is quite low. So what are the weird cells that we see when we look down the microscope? Well, our granulocytes or neutrophils, they might have a lack of dots in the neutrophils. The cell at the top there with the two funny shaped lobes has got a reduced granular appearance. So that's called hypogranular. You might also have these ones that just have two lobes. Normal would be between about 3 and 4. And that reminds you of those old opera glasses or pince-nez that we used to balance on the end of our nose. So that's a very characteristic finding in myelodysplasia. But it could even be down to one single lobe, which is very abnormal. And these are megakaryocytes. And what fractures off this are the platelets. So these are the platelet-forming cells that we normally see in the marrow, but these don't look normal. So we might end up with having a low platelet count, but also their function is quite abnormal. So this is just now we classify everything, as you can imagine, and it's a spectrum. We know that people don't just develop myelodysplasia. There's probably a spectrum of disease that might take many, many years. And some people never go on to develop myelodysplasia, but they're somewhere on this spectrum. So at this end, in what we call CHIP, which is clonal hematopoiesis here of indeterminate significance, means that very few of these people are actually going to go on to develop myelodysplasia. But by the time you're towards this end of the spectrum, it's very likely that you are. So we've already said that MDS, which is its short term, is thought to arise from clonal hematopoiesis. But we all know as we age that we acquire mutations. And those occur in all of our tissues, but stem cells and blood cells particularly. So it's kind of a spectrum, if you like, of molecular decay. So we're all undergoing it. So some people have looked at what we call normal, healthy people. And what they've found, even in the healthiest people who don't have any abnormalities in their numbers in the blood, might have around 50% of people have mutations by the age of 80. Some of those mutations end up proliferating. So this is quite a good analogy of a light switch. It's like going out, leaving the light switch turned on, and it doesn't matter if it's on the on or off position, it's still driving the bone marrow to make more cells. So that tends to cause a proliferative problem. Myelodysplastic syndrome has been recognised for more than 100 years, and it started off being called leukanemy. Subsequently, we've gone through all sorts of jargon and new terms, new findings from refractory anemia in the 1930s. But the actual terminology of myelodysplastic syndrome was around about 1982. And that's what we learned from the French, American, British classification. So that's one of the older fashioned types of classification. We, who grew up in the time where we were still using it, still refer to it. But really, we've moved on, and I'll talk to you a little bit about other types of classifications as well. So it's quite a complex hematological problem because there isn't one identifying factor that we could do a simple test and say, yes, you've got it and you haven't. Sadly, it's not quite as easy as that. So what we do is use a different number of, we use those differences in disease progression, how it presents, what the outcome is, and we use a classification system to try and help us. And really, what's the point of that? Well, it helps us get the diagnosis right. It informs us about what the likely statistics tell us about your outcome and guides us to which might be the better treatment for you. But sadly, as I said, we don't have one test that will tell us all. In 2008, the WHO, so World Health Organization, defined and published, but they've since gone through about 3 more publications since then. So it gets more and more complicated as we learn more about this condition. So they defined that it's a group of clonal hematopoietic stem cell diseases characterized by low blood counts, abnormalities or dysfunction, ineffective hematopoiesis, and an increased risk of developing acute myeloid leukemia in the future. But they said, well, we can't call it that if all of your blood counts are normal. So they set thresholds below which your hemoglobin less than 100, your neutrophil count less than 1.8 times 10 to the 9 per litre, and platelets less than 100 times 10 to the 9 per litre. You have to be below those levels in order to say it's truly myelodysplasia. So what happens from the start? Well, we have a suspicion that you might have a low blood count, so we decide we better have a look into it a bit further. So it's on the basis of those abnormalities in your blood count. But we have to look at, have we excluded all the other things first? So we'll talk about what we might need to exclude first. Well, it could be that you're on medications that are going to affect your blood counts. It could be that you have a deficiency, something that's easy to replace like B12 or folate. But now we recognize that things like zinc and copper are also quite important. So we sometimes check those levels as well. If you have an excessive amount of alcohol, then that can affect, it directly suppresses the bone marrow. So sometimes it's a case of saying, well, if you cut back, you might find that your blood counts improve. It could be that you've worked with some sort of heavy metals or benzenes in the petrochemical industry in the past. It could be that you've had an infection and it's just a temporary thing that will recover. It could be that you're anemic because of something else that's going on in your body. So it's sort of a coincidence that you've got some of these features of dysplasia. Or it could be that you've developed an antibody to your own blood cells, what we call an autoimmune condition, and that's dropping your blood counts as well. And then there are things like your liver and kidneys not working properly. So we have to think of all of those things before we even start thinking about the blood side of things. And then we have to assess what is it in your history that may tell us a bit more. And it could be that you've previously received chemotherapy 10 years ago for another problem. And now we're seeing some of the effects on your blood in the future. And then, as you were present for Peter Browett's talk this morning, you talked about this condition called PNH, which is incredibly rare. There's maybe 20 people in New Zealand with it, but they might have an increased chance of having an abnormal blood count. And then there are obviously some constitutional disorders. And one in particular, of course, is Down syndrome. And we know that the risk of developing myelodysplasia or acute myeloid leukemia is higher in those sorts of disorders. So there's the hereditary factors when we meet somebody with myelodysplasia, we ask all about their family history, their personal history, their drug history, their social history, all of these things. And then in our acquired side, that could be, as we've said, these mutagens. So you might have received etoposide as a drug for some other problem like lymphoma, but many years ago. And so those are things that we have to take into account. Tobacco, obviously, is a known risk. So reducing or stopping smoking is really important. And then sadly, just getting older is also a risk factor. So how does age come into it? Well, this data is taken from 2007. It's New Zealand data. And what it shows here, at the age of 70, we're looking at around about 40 or 50 people in every 100,000 who might start to show myelodysplasia. But as you go further along the graph on those over the age of 80, that significantly increases. This is more recent data. This is American data, but from 2017, the number of new patients diagnosed with myelodysplasia over the age of 70 was 25 in 100,000, or 1 in 4,000 people. So we are seeing it increasingly. So incidence means the number of new people with it, and the mean age or the average age where people present is 65. But that can be quite different in different populations. So for example, in India, the average age is 45, quite significantly different. The incidence from the USA is around 4 per 100,000, and it constitutes about 1.3% of all cancer registrations in New Zealand. It is more common in men than women. And as you get older, that increases so that it's almost threefold by the age of 80. So what's the easiest thing to do? Well, the easiest thing for us as hematologists is to look down the microscope and say, yeah, that doesn't look quite right. That's years of experience and expertise. So we can say, yes, it's very likely this person has myelodysplasia, but we can't confirm it using morphology alone, so the microscope alone. So we might have to then ask for some additional tests, and that could be what we call flow cytometry or molecular studies. But the advantage of our screening process is that it's quite simple and cheap, other than having a hematologist have a look. But it's almost immediate. So we've now got our combination of our blood counts. We've excluded all those other causes here. So the next step is to look at the bone marrow. So we take a sample from the bone marrow, and that's really what we base our diagnosis on. It might be in a very elderly person that they're too frail, or they think, well, why I don't want to go through having a bone marrow, and that's fine. So, but often we then have to say possible myelodysplasia rather than confirmed. So what we're looking for is more than 10% of the cells in the bone marrow being dysplastic. So if we only see 1 or 2, that's not enough to make that diagnosis. But it might tell us, well, we need to keep an eye on this. And then we do these fancy things like you were hearing from Peter earlier today, a karyotype, which is cytogenetics, and I'll show you a picture of that in a bit. And then this FISH testing or mutation analysis that's now telling us even more information about the process. So we're on to our 5th edition now of the WHO classification. And what that does is incorporate all of those clever new fancy tests. So way back in 2008, then we just had some sort of basic classifications now. But now we can actually identify the exact mutation. And that tells us a lot more about what's likely to go on from there. Why do we bother? Well, as we've heard earlier, it helps us unravel that disease biology. That means that we can diagnose it and get diagnostic tests that are much better. We can try and predict your prognosis. You have to remember, statistics can tell you a whole range of things, doesn't necessarily tell you exactly what's going to happen to you as an individual. And then that information can be put into trying to work out new models that we can use to treat. So you may have heard of some of these prognostic scores. The first one is the WHO-based prognostic score. And then we had the International Prognostic Score, which has then been revised since then. Why would we have more than one? Well, of course, these things come from where the research was done. The Americans, North Americans, tend to use the IPSS and quote all of their data and information regarding that. And then Europe tends to go more with the WHO. WHO was aiming to be universal, but obviously we all like what we're more familiar with. But that means that you might have 2 different scores with just fractionally different results. It is basically works in to give you the full answer though. So this is a diagram of what it involves. You can see at the top there, it's about our morphology, our classification. And then we add in the additional tests from the karyotype or the chromosome analysis and what your hemoglobin is, whether it's above or below a certain level. And that comes out with a risk score that goes from very, very low to very high. And that estimates how long you might be going forward from there before you run into some problems. But these are averages. So some people are obviously going to do a bit better and some people not quite so well. So this is the revised IPSS score. It works in a very similar way, as in it uses the information from your cytogenetic analysis, which is there at the top, and then all sorts of parameters to do with what we see in the bone marrow in terms of the number of blast cells or leukemic type cells that we see, and what your hemoglobin, platelet count, and neutrophils are as well. And then again, gives us a risk between very low and very high. So broadly, we then have what we term the lower risk groups, which counts the low and intermediate 1 on the original score, or very low, low, and intermediate in the revised score, or the higher risk groups, which is intermediate, high, and very high. How does that help us? Well, when we're looking at treatment options for myelodysplasia, it might be that some are appropriate if you're at the lower end of the spectrum, and some if you're already towards the higher end of the spectrum. So we'll run through a few of those treatment options. What is the primary goal that we're aiming for if we have a low risk patient? Well, ultimately, it's about your quality of life. Okay. Do you need treatment at all? And obviously being told that you have a condition and then someone saying, but you don't need anything, don't have anything just yet, seems really odd, because you want to get on and you want to have something, or what can I do to make it better? But actually, lots of studies have shown that treating early and aggressively actually doesn't change the outcome. It might be hard to think about living with it, but when you consider what you go through in the form of treatment, you actually need to keep that idea of quality of life in your mind as much as possible. Because going to hospital every week or every day or every fortnight is actually takes quite a lot out of your normal everyday life, being home with the people that you love or doing the jobs and activities that you enjoy. So it's about keeping that quality of life for as long as possible. So that means that often observation alone is really the best choice. Some people say, well, is a transfusion a treatment? Well, it's not a treatment, really. It's support. It might actually start to indicate, if you suddenly need to have transfusions, that treatment might be suggested or is an option to consider. But it isn't actually a treatment on its own. What are the special things that we should think about? Well, we talk about this thing called erythropoietin, and I'll talk to you about what that means. We have to do a test on your blood to see what your actual level is. And then there might be some very specific types of MDS that have a particular abnormality, such as what we call 5q minus, and I'll give you a bit more information about that shortly. That's the long arm of chromosome 5 being wiped out. But what we know is that might enable you to respond to a particular type of treatment rather than anything else. If you are younger, and as we know, we've already said your average age at being diagnosed is 65, so we're already a little bit over that. But if you are very young, you might have something that looks a bit more like aplastic anemia, where the bone marrow just isn't making enough of the cells. And you might actually benefit from the type of treatment that we use for aplastic anemia instead of myelodysplasia. But it is something that you have to be on the younger side to manage. And then the other thing to consider is around iron overload, and I'll explain a little bit more about that too. So why do we sometimes check an erythropoietin level? Well, some of us may remember erythropoietin from Lance Armstrong. It's an erythrocyte stimulating factor. So it's a growth factor, and it only works on the red cells. Okay. It's a natural hormone that we actually make in our own bodies, but we have a recombinant form where we can give it to you if you haven't got enough of it. It has to be given as an injection under the skin. There isn't a tablet for it. And in New Zealand, what we say is that you have to have an erythropoietin level less than 500 to be eligible to receive it. And this is why. So the studies showed, if you use this point system, if your level was greater than 500, then your chance of responding to this was really only 5 or 10%. Whereas if your level is at the lower end of the spectrum, certainly below 500, but ideally less than 100, then you've got almost a 75% chance of responding to erythropoietin. And what would be the advantage of that? Well, that means that you might have this as an injection that you can give yourself at home, a bit like diabetics might give themselves insulin, and you don't have to have blood transfusions. So it saves you all that hassle of going to the hospital, having a blood test, staying there while you receive a blood transfusion, and then going home, waiting while the effects tail off, and then you get another one and you feel well for a while, and then the effects tail off again. This gives you a nice, flatter feeling of well-being and response. So certainly worth looking into. So now we'll talk a little bit about that 5q minus and why it might be important. So this is from the American National Cancer Institute, What they've said is that if you have a symptomatic anemia, the first thing is to look whether you have this deletion of the long arm of chromosome 5, because that could be useful to know. So this is conventional cytogenetics. So this is how your chromosomes line up when they're done properly. They don't look like this in us, sadly. They're not that well behaved. But you can see at the top there, chromosome 5, that one is shorter than the other one. So that is a 5q minus. It's lost its little bit off the end. And there's another way that we can look for this. So this is what's called FISH, or fluorescent in situ hybridization. And basically we attach probes, and you can see at the top that the green one is going on the short arm and the red one is going on the long arm. Normally you'd see 2 of each in every cell, like you see at the diagram at the top. But in this here, you can see we've still got our 2 greens. So we've got 2 short arms, but we're down to 1 long arm. So this is another way that we can determine that that 5q has disappeared. And it could be that we tried your cytogenetics, we get the answer from that. So we don't really need to do this. But sometimes that cytogenetics doesn't work well because we have to grow those chromosomes. So sometimes we get a fail. And then this test can be done just on blood taken from your arm and sent off to the laboratory. And why is this important? Well, this particular abnormality shows really high response rates to a drug that we typically use in myeloma, not in myeloid problems. But lenalidomide, when it was used in this particular case, has up to 70% response rates. And that means those people become transfusion independent or free for more than 2 years in a lot of cases. But it's only if you have that specific abnormality. So that's why we might look out for that. I've already explained that there are some people who have myelodysplasia that looks a little bit more like aplastic anemia. In other words, it's just quite empty. There's not a lot going on in the marrow instead of that full picture that we had at the start. And so if you have too few cells, what it's thought to have happened is that your own immune system is trying to attack your bone marrow. So what we do is immunosuppress you, or reduce the effects of your bone marrow, your immune system, so that it then allows your bone marrow to recover. And it's a combination of these drugs called anti-thymocyte globulin and cyclosporin, but really it's pretty tough. And it can take quite a while to work. It means that you might need to be in hospital. And it also means that you might be very, very susceptible to infections for quite some months or even longer. So it's not to be done in someone lightly. So we have to select those patients quite carefully. But it could be an option that might be useful. I said that I'd talk to you a little bit about iron and the balance that we have. So our bodies are normally in kind of a balance with iron. We would have around about 3 or 4 grams of iron in the body at any time. And our daily intake is usually balanced by what we lose. But for every 3 units of red cells that we receive, we're putting more than what we should have in there. And it tends to accumulate in the wrong places because it's quite hard to get rid of just by normal excretion. So the places that we worry about it sitting in is your heart and your liver. So multiple transfusions over many years have a build-up effect in the iron in your body. So that's why iron could be important, and why we don't try and transfuse people back up to normal, because they might be sitting with a hemoglobin of 80. We don't need it to be 120. If it's above 85 to 90, you might feel good enough, but you would be reducing the amount of iron that you're taking in. So when we come on to the higher risks, we're looking at this end of the spectrum. So those that we consider poor or very poor. And the overall survival in these cases are really quite short. What can we think about in these cases? Well, first of all, the important thing when you meet the doctor and you're having your discussion is really that decision, are you fit in medical terms? Not just can you run around the park, but fit from the point of view of your organs, your health, any other problems, how you normally are living an active life. And if you are fit, you might be eligible for a stem cell transplant, which requires having somebody with an identical HLA type as you have to put their stem cells in and allow it to recover in your bone marrow. And you might go through chemotherapy before those stem cells are put in, or in some cases, they might just go straight into it. But then otherwise, the commonest treatment that we have is a drug called azacitidine. And that's a hypomethylating agent, which sounds very clever, but basically it affects the DNA. So it's trying to change that cell. So it is something that doesn't work with the very first course that you receive. It might take 3 to 6 months before it starts working properly. So it has to be given time. It's usually given as a subcutaneous injection, so a little injection under the skin, but it's often given for 7 days every 28 days. And there's some logistics around that. It's how far away from the treating centre are you? Can you give your own? Can it be safely delivered to you? Because it's actually got quite a short life once it's made up for it to be active. So there's a number of issues that come into that, particularly if you live in a very rural area away from the treating hematology site. So obviously people would really like to see whether there is a tablet form of this. So at the moment, this drug called decitabine is from the same family of drugs, but is an oral tablet. That's clearly going to be a bit better for people to manage in terms of how the logistics go. But the studies are looking at, is it as effective? Now, it's important to realize with either of these treatments that this does not result in cure of the disease. It will control it potentially for some time. That time could be years, but it will not ultimately cure the disease. But where is this field of research going? Well, as we heard earlier today, it's a really active field of research. Myelodysplasia and the number of drugs and the number of families of drugs is growing all of the time. It's really important that people in New Zealand might be eligible for a clinical trial, because that might give them access to a drug that they may not otherwise be eligible to receive. So that's the importance of where we're going. I'm not going to go through this list, but clearly that would take quite a long time. But it just shows there are many options on the horizon. And just to finish off for you, I just wanted to get you to consider or think about your options. So we talk about shared decision making. So it's really important that you share information with your doctor, but they allow you to participate in that decision making as well, so that you agree that management plan between you. You think about how those treatment decisions are really personal to you. And it's important, what could be very important to you and what you consider your quality of life might not be the same as the next person. So it's about considering that very carefully for yourselves. And these are some things that I would suggest that you might, want to think about when you're considering any form of treatment, whether it's for myelodysplasia or anything else. What you want, how it might differ from someone else, how much of an impact it's going to have, whether that's on your lifestyle, your travel. Do you have to spend a week in Dunedin instead of being at home? You know, all of those factors come into it. And that's what shared decision making is about. Not being told this is the treatment you should have, but how it might impact. And you can pose or think about your own questions to take along with you. Well, what if I don't have treatment? What will happen? How does my age or my health or my other issues affect it? Because that could change what might be recommended for you. Can I access a clinical trial? We've talked about that being important because it might give you an option that's not currently available to you. And if I don't do anything now and choose to do something later, what would be the decisions around why I would choose to do something? So these are all things that you could think about. And then when it comes to treatment itself, it's like, how do I make those choices? How do you guide me? But what do I want to gain from this? How long before I have to make the decision? If we're at the very poor end of the spectrum, those length of time to think about things might be relatively quick because we want to do something that's going to make an impact soon. But if we're at the less risky end of the spectrum, it's not something that you have to decide today. It could be that you want to gather the information before making a decision. And then, you know, going forward, it's like, how do I get my family involved? How do I actually receive these treatments? What's the logistics of it as well? So I'm happy if you have specific questions. And obviously, it's quite difficult to talk about individual cases, but I'll try and talk about themes if you have questions. And just on a lighter note, we can all think about how we grow our stem cells. Thank you.
You said about the 2% of
Yes.
So that is healthy.
Yeah, so if we look at the bone marrow or at the blood film, and there's only 1 or 2 abnormal cells, but the majority of them look all normal, that wouldn't be enough to say, oh, we're suspicious enough to do the next step, which might be a bone marrow or a special blood test that we send away for a karyotype or a molecular analysis. Whereas if we look and we go, actually, there are 50%, so we better do those tests now. So yes, it is a spectrum. It's not necessarily that we see, you know, it change, because we don't necessarily aim to do bone marrows very regularly. I'm sure that you wouldn't really appreciate that. But it's how much suspicion do we have is now the right time to do those further investigations. And it could be that we just watch your blood counts, or your local general practitioner might be just monitoring your blood count. And that might be in the early stages a mild anemia that then slowly over time changes. That's the point that we might go, okay, now we have more than 10%, we're going to look into it.
So, dumb question, the iron, does that mean that if you're suspect of MDS, you should lower your bed need?
No, well, that's a bit of a double-edged sword. The problem is everybody needs iron. So normal cells need iron in order to replicate. So not just red cells, but they're the majority of the consumption. But all of our tissues need a bit of iron to work properly. Normally, your body will regulate it. What it means is that, you know, if you take a nice big juicy steak, you won't absorb, or your body won't absorb all of the iron from that if you've already had, I don't know, iron in your breakfast cereal and this, that, and the other for the day. So your body usually regulates it. Doesn't matter how much you put in, it'll get rid of what's the excess. The problem is it's taken into the red cells, but it's not formed into hemoglobin properly. And therefore it's there, it's in excess, but it's not in the right place. And that's the hardest thing, because even cutting back, your body will still aim to absorb iron because it recognizes it needs it, but it's how it uses it that becomes the problem. And that's really hard to change. But yeah, I mean, there are recommendations in terms of what's the minimum amount, but also there's recommendations, for example, the same in, say, hemochromatosis, which is a disorder that makes you absorb more iron than you should. Maybe red meat no more than 3 times in a week. So the majority of types of chemotherapy are not so specific, so they only hit the bad cells. They kind of affect the good cells as well. And they affect the cells that, as we said, they have that choice to divide. And so they're hitting the ability before you've even made the red cells to form normal red cells. So over time, you become more anemic just from any form of chemotherapy itself because of its dampening effect on the bone marrow. So it's not that, say, the azacitidine, for example, only targets the abnormal cells. It has a sort of a bit of a blanket effect on several things as well.
So your stem cell transplant, does that fix MDS or does it just slow it down?
So obviously it's a very specialized field and not everybody, as we've said, will be eligible for it. Okay. So in those people, though, they may be cured because what grows back in the bone marrow is the donor stem cells, which are healthy, rather than your own. So it sort of clears out the cupboard, if you like, and allows the donor cells that are put in to regrow your bone marrow.
Yeah, but I've had a stem cell transplant, so you've got own cells.
Right. For myelodysplasia.
No.
So yes. So your own stem cells wouldn't work for this condition. They do for myeloma because they reduce the overall burden of disease. But in this case, the only type of stem cell that potentially could cure it is using somebody else's, what we call an allo transplant or a haplo transplant. Yeah. Yeah.
But just on transplant, well, for our patients that will see this video later on, a lot of them ask us when we come to puberty, say, oh, I'm the first patient, he's going to do self-transplant.
So it's kind of that one size doesn't fit all. They have the doctor, the treating doctor, has to weigh up all the good points and all the bad points and work out, is it safe, first of all, for you to go it. So it's not totally on age, but it's about our not our numerical age, if you like, but our fitness, our age in our bodies, if you like, and how fit and healthy you are. So you could have a really fit 72-year-old or a really not fit 62-year-old, but you might offer it even to the 72-year-old, but not the 62 if they've got other problems. So it's about there's a sort of scoring system, if you like, that's to do with how well your heart, your kidneys, your liver, your lungs, how many infections you've had, all of those things are weighed up before even contemplating it. And then you have to have a match. So obviously, there are donor registries out there. There are people who volunteer to donate. There might be a relative who's a match. But even if you have 10 brothers and sisters, it's not possible that every single one of them will match you. So it's about finding the right match as well. So it's more than one factor comes into it. But also it's around the risk. So if you're in a low risk category of myelodysplasia, actually the risks of going through that transplant could be greater than what your benefit is actually going to be, because there's a more immediate risk of having complications of a transplant, even in the first 100 days. Whereas if you have a low risk myelodysplasia, your life expectancy might be 10 years. So it's that balance. So there's no definite right or wrong answer, but it's about having a discussion and that concept of shared decision making. So aplastic anemia traditionally doesn't meet that criteria of the 10% dysplasia. So what's there is normal, there's just too little of it. So you might, that diagram or picture that I showed with normal bone marrow and the fat spaces, we think of normal cellularity of being at least 30%. So there are spaces, but 30% will be cells. And often in aplastic anemia, that percentage is down to like less than 10% actual cells present at all. So it's just lack of them, but what's there is actually quite normal.